All right, guys, good afternoon. It's 4:05 and we have already a quorum trickling in for today's NASCI's Curious Cases webinar. As you know, we hold this webinar where we all show interesting cases to each other and hopefully get some good comments and feedback from people, and we start a good conversation. We do it the first Tuesday of every month at 4 o'clock Eastern time. So today, no differently, we're gonna start showing some cases. My name is Jacob Kirsch. I'll be running the webinar today. So any of you have any cases that you want to show, let me know. I can definitely share the presentation with you guys so you can share cases, ask questions about your cases if that's what you want to do, or just do like a little show and tell. Again, everybody is welcome to share what they see in their practice. We all come from different practices, backgrounds, so we have different type of cases and populations. So we're all very interested in whatever that you see. We would all love to see it as well. So don't be shy and share with the group. Also, we have a chat room here in the GoToMeeting, so feel free to put notes there and use that to participate throughout the meeting. And always just feel free to unmute yourselves and make comments or ask questions as we go. But when you're not speaking, please keep yourself on mute so we avoid background noise. I assume everybody can see my screen. So I was testing that earlier. So why don't we go ahead? Let me switch now and put my presentation. So I only have a couple of cases today. So hopefully we'll have some from you guys to try and fill as much time as possible. All right, let me see. Let's get this started here. There you go. All right. So without further ado, this is for June 21. I prepare a couple of cases to share with you guys. But before we go, this is just a screenshot of the email that we get as a reminder. If you are a NASCI member, you probably are getting these emails. And again, if you are a trainee, you can become a member of NASCI as a trainee as well and receive all the notifications of all the educational material that we do. But I want to draw your attention here at the very bottom of your email. You see all those small logos. So you can add the webinar to your calendar. So you get reminders and you can set it up to remind you an hour before, a day before, what have you. So you don't forget to join us. Even though I know we put a fair amount of notes on Twitter and via email and Facebook, it sometimes, we're at work. So it's nice to have that reminder pop up on our calendar that we like to use, Google Calendar or Apple Calendar or Outlook, etc. So make sure to hit those links on your email and set it on your calendar. If not, you can do it also manually on your calendar application so that you have those reminders. All right, the first case is this is a very interesting case. It's a bit of an unfortunate case, and I actually posted this on Twitter. I know some of you had a chance to see. I just posted a little teaser inviting people for the great reveal today, I guess. This is a 59-year-old male. I was on call. It was over the weekend. I opened the chest CT for a follow-up, and so this is what I saw. So I'm just gonna slowly let it run because I know there's some delay on the streaming. So you can see way too many findings in this chest. So I'm gonna take the cursor now and walk you through some of those. So the first thing is we'll go all the way to the top here. You see it's a patient that's in the surgical ICU. You see there's an endotracheal tube. You see the sternotomy is open, and you see all of those large bore tubes going into the patient through the sternotomy. You also see a line in the brachiocephalic vein and another line in the right jugular vein going down. So number one, you see these large bore tubes going into the aorta. They're on the SVC as well. And then you see the one in the SVC that goes all the way down through the IVC. And you see also this large bore catheter down at the base of the heart there. So again, large 4 catheters. These are all ECMO catheters for the patient. So if the patient was on support with ECMO, was intubated. You see here a Swan-Ganz catheter going to the right pulmonary artery, terminating right there at the RPA. And then as I'm looking at this study, a couple of things came to my attention. Number one is it's a relatively small looking heart. It doesn't look like it's one of those chronic dilated cardiomyopathies, patients with horrible dysfunction that require to be on ECMO. It looks otherwise like a normal sized heart. There's not a lot going on. The pericardium looks fine. There's no big effusions. It was when I was looking at it, it was like, okay, this is kind of odd. The heart doesn't look that terribly sick. There's not a lot of plaque, etc. I mean, the coronary plaque. And then I saw this unplatzer occluder device, and the location is unusual. We are very used to see it in the interatrial septum, because it's a septal occluder device, but that's the official name, I guess. But this is way below, seems to be almost within the ventricles. So I started looking at the reconstructions, trying to figure out what was going on. So this is here a coronal reconstruction. Gonna let it scroll. We don't have to talk about all the tubes and lines here. So let's see. Let's stop it here and bring it back to where we see the occluder device. And there we see the left atrium, and we continue to move anteriorly. We see the mitral plane, so it's not there. But then we see it right here, very posterior to the ventricles, I guess, and just below the LVOT or the aortic root. So in the area of the membranous septum almost. So I'm like, okay, so maybe there was a membranous septum defect, which, they do happen. So that was my first theory. And then I looked at the sagittals as well. And we're getting to the heart. And here again, we see it kind of below the RVOT. Again, almost, very anterior to the mitral plane. So at the level of the ventricles and the posterior ventricles. And again, there we see it right there. So very weird position. So before I move to the next one, I'm going to move to the next one actually before I ask questions or take comments. I was looking for old studies for comparison, and there were all these, chest X-rays from the unit, tubes and lines in place, yada yada. And then there was a previous CT, and here it is, because I wanted to see just what was going on. And we saw there was something in the axilla. This is from an outside institution. I don't know why they were doing there. They were doing some biopsies or what. There's some fluid in the right axilla. But when you look at the heart, let it stop. I mean, it looks pretty normal. Looks pretty good. Looks good in size. Again, very little coronary plaque. All the vessels look fine. So I'm like, okay, this is not very exciting. So anybody wants to make any comments before I move on with some echo imaging? All right. So I at this point, of course, I was very intrigued. I went back to look at the prior studies, and I looked at the chart, and then I found out exactly what was going on with this patient. This is a patient that had hypertrophic obstructive cardiomyopathy. So severe HOCM, with severe gradient across the LVOT. So I went to look back at the echo and the images. There was no MRI, which would have been great because we are cardiac radiologists. We love to look at MRI. But I found these images, and these are transesophageal. So you have to kind of look at it differently than if you're looking at transthoracic. Things may be a little bit backwards. But you can see here, this is the LVOT, this is the aorta, and you see this bright thing here moving inside of it. Anybody wants to guess what that is? Okay, so that is a scalpel. So this is a patient with hypertrophic obstructive cardiomyopathy that was undergoing myectomy. to release that obstruction at the LVOT, that obstructive pathophysiology with elevated velocities that we commonly see as part of the HOCM pathophysiology. So this patient was undergoing a septal myectomy to get some of that muscle that's really hypertrophied out of the way. And as I was looking at the images, then the next image I see further down the series is this one. So again, this is a transesophageal. So you see the, the echo is coming from behind the left atrium. That's a left atrium there. And then we see there's a huge ventricular septal defect right at the site where they were cutting the myocardium to open up the LVOT. So this is a iatrogenic VSD post-myectomy that's just very large and severe. And that's when the patient went immediately into heart failure due to the large amount of shunting. So they had to call in the structural cardiologist to the OR to put in that Amplatz Weiter occluder at this level. And that's what we're seeing. And this just, this was done guided by transthoracic echo. You can see the probe there at the very top. You can see already some of the cannulation in the heart, and you can see they're deploying the occluder device into place. This was done without contrast because they were giving guidance by echo, and the orifice was large enough that they really didn't need to inject contrast into the heart to see it. So that's this is just a case of a horrible complication of a septal myectomy to treat hypertrophic cardiomyopathy. So this is how they do it. Patients they undergo a small thoracotomy about the top of the chest and the top of the sternum, and then they do an aortotomy. So they open the aorta around the mid-ascending level, and then through that they put the scalpel, and somewhat blindly just gonna scrape off pieces of muscle of that hypertrophied septum to try and again to open up the LVOT. And in expert hands, it's a pretty safe procedure. People that have good experience, because again, it's a bit of a blind procedure. You have very little visibility into what you're doing as soon as you put your scalpel below the aortic valve level. To the right of your screen there, you see a case, and you see those chunks of muscle that they were scraping off when they were cutting into the myocardium. And those actually, that pathology image is from the next images here. So you can see what it looks like on MR. So you have two images. On the right is pre, and on above and below is post. Again, this is the same patient pre and post myectomy. You can see how tight it was there, the LVOT, and then the significant relief of that obstruction after the myectomy. So this is the ideal result. This is how it should look. A surgeon that performs this in high volumes, he told me that patients, as soon as they wake up from anesthesia, feel significant relief, that they immediately say how much better they feel clinically after this procedure. So to some degree, it's minimally invasive. It's just a small mini thoracotomy with a small aortotomy, but it's not big open heart surgery with a mini sternotomy. But it has clearly its challenges and its complications in the case that I showed earlier. Another complication, and then I went back to my archives just to see, because I remember having this one. And, if you see this another complication of septal myectomy. I'm going to stop this and see if we can see it better. Let's see, there's one specific image that I know you can see it to some degree. But as you can imagine, you're trying to put a long scalpel through the aortic valve plane, and you can see here this redundancy of the aortic leaflet. So this patient, they injured the leaflet when they were trying to go through with the scalpel, so they had to try to go back in and stitch it together. Otherwise, basically, you're leaving the patient with aortic insufficiency. So this is a post-repair. Patient came back not to look at the valve necessarily, but to see if there, to some degree, because that was part of the assessment, to see if there was any residual aortic insufficiency after the repair, and it was really trivial. But that's another one of the complications or risk of this procedure of putting the scalpel, again, somewhat blindly, which is not the right term, but the visibility is limited. To put it through the aortic valve plane, you can definitely injure one of the aortic valve leaflets. All right, so any comments or questions about these patients and these procedures?
So when they're doing that myomectomy, they're only taking out right in that LVOT, just at the
Correct.
site of obstruction, correct? Just below the aortic.
Correct. Correct. So it's again, yes, correct. So this is a treatment that's used for hypertrophic obstructive cardiomyopathy when the base and the septal areas are involved, right? When you have mid-ventricular HOCM or apical HOCM, it would not be helpful for those cases. However, that these are the patients that are going to be the most symptomatic, those that have that obstructive pathophysiology at the LVOT. Those are the ones that are going to be more symptomatic from a clinical point of view. They all may have the risk of sudden cardiac death because of areas of myocyte disarray that can be sources of ectopic heartbeats, etc. So they're all going to have that electrical risk of cardiac death at some degree, some more than others. There's some data to suggest that the apical HOCM has less of that. But again, for the clinical presentation, for the symptoms, it is used mainly for that basal hypertrophy or circumferential, more generalized hypertrophy, just trying to open up that LVOT. Anybody else wants to add anything? Dr. Denny, Dr. Ordovas, Dr. Drexler? All right. So that's one of the two cases I wanted to share with you guys today. And this is case number 2. And actually, I'm glad Dr. Drexler's on the call because he may have more information than me about the case. It's a 75-year-old male presented to the emergency department with chest pain and shortness of breath. So, of course, we got an order for a rule-out PE study. So we did a CTA of the pulmonary arteries. I'm going to let the images scroll somewhat slowly so that you can catch up on the streaming. Some of the measurements are showing up. It's giving away the answer. All right, so I'm going to now kind of drag. So there's a few things. There's a trace pericardial effusion there, or small pericardial effusion. There's some coronary calcifications, and there's some significant coronary calcification there in the LAD, and it's always good to look at the left ventricular myocardium perfusion when you have plaque. Patients with chest pain, could be an acute MI. You may be able to see areas of hyperperfusion and potentially help the patient and the clinicians with that assessment. And then we have this finding. So we have, if you look at the, actually, does anybody want to tell me what I'm looking at? Any brave souls there? Before we look at this, there you go. So we have this lobulated soft tissue density filling defect in the SBC. You can see it there. It seems to be a bit infiltrative, maybe infiltrating into the fat planes around it, and even there posteriorly abutting and probably infiltrating into the pulmonary artery a little bit there on the right PA and above it. So again, very lobulated. It doesn't look like layering contrast. There's good contrast opacification of the SVC. There's some contrast going into the azygos arch, clearly because of that, not being able to go into that SVC. Or the transit is somewhat limited, but there's good opacification of the cardiac chamber, so the contrast is getting through. So, your differential considerations here are going to be thrombus versus neoplasm. The patient also had a few pulmonary nodules, small ones. So we thought initially this could be, a sarcoma that was, high in our differential. There's a large lobulated infiltrative mass there in the SVC, and we know that we get large vessel sarcomas once in a while. We'll see them in several of the arteries in our chest or veins. So patient went for staging and to see if there was any other FDG avid lymph nodes or something more superficial for biopsy, so they wouldn't have to go in and try to biopsy the SVC, something that may be a little bit easier and safer. And that's where the PET comes into play. Again, looking for a more amenable to biopsy site. And you can see here, waiting for the images to catch up right there. So right immediately you see that mass within the SVC is highly FDG avid, so it's taking up the glucose quite avidly, which is very suggestive of neoplasm, more consistent with neoplasm. And again, you see how it was. There's a few tiny nodes there in the mediastinum and the right hilum that are FDG avid as well. Again, suggestive of some metastatic involvement. And then we had this little nodule here in the lung in the right apex, which was also highly FDG avid. The other ones were very small. Remember, the spatial resolution for PET is about 8 millimeters, so things below 8 millimeters may not be perceptible by PET, depending on how much FDG activity they're uptaking. So, any guesses what this turned out to be? And there's a lymph node there also.
I guess metastatic is maybe metastases from a pulmonary primary, whereas the SVC mass, is that the primary, the sarcoma?
Yeah, that's a great thought. Those are both great thoughts. Just based on the size, we first thought, oh, this is going to be a sarcoma with some lung and nodal mets. But common things being common, this turned out to be a lung primary with mets to the SVC and lymph nodes. So even though that nodule in the right apex seems to be very small, that's what started this whole mess for the patient. So the patient now has a stent in the SVC, and it's either just started or it's about to start the radiation therapy to the chest. So again, it seems to be a somewhat aggressive tumors. It's metastatic everywhere, even though it's a small primary lung neoplasm. Dr. Drexler, anything that I forgot to mention about this case? Did we lose Dr. Drexler? Yes. I know that he read the PET, but he just logged out. He knew that I was going to be calling on him. Any comments about this case? All right, perfect. So those were the two cases that I had prepared. Yes, that's it. Anybody on the line who has a case they want to share with the team?
I do if no one else does.
Even if somebody else does, we want to see your cases. Carol. You always has great cases.
Yeah.
All right. How are you? Good?
I'm good. Yourself?
Oh, never better. All right. Let me make
you guys had a holiday. That's nice.
Yes. Oh, that's true. Yeah. All right. I am sharing with you.
Okay.
There you go.
Can see my screen?
Yes, we can see your screen.
Okay. So this is a 51-year-old man who presented with flushing, palpitations, and diarrhea. So I think what you can see is that there's some restriction of the posterior leaflet of the mitral valve. There's a bit of thickening of the aortic valve, and there's aortic regurgitation on the, oh, this one isn't moving. On the 3-chamber view of the right ventricle, oh, I should have downloaded the 4-chamber view. The tricuspid valve is restricted. It's not opening well at all. And so there's tricuspid stenosis, and there's also significant regurgitation. The pulmonic valve is thickened, and there's pulmonic stenosis and regurgitation as well. So any idea what this might represent, especially the right heart? The right ventricle is dilated.
So a carcinoid.
Fabulous. Maybe. That's really good. Yeah. There might be a couple of little filling defects too in the right ventricle and the outflow tract, and then also at the base of the LV. But yeah, so this patient had colonoscopy and had a terminal ileal carcinoid tumor. Is there any, I know you can get carcinoid tumor without having metastatic disease, but is there any evidence of METs in this patient?
So yeah, I mean, I guess image on the far right, it looks like there's a mass in the kind of mid portion of the liver.
Yeah, so there's multiple hepatic lesions. The largest one is pretty visible there. So he presented with metastases and carcinoid syndrome all at the time of presentation. It's pretty rare to have left heart involvement. They say that it usually occurs in the presence of a PFO, but in this patient they didn't see a PFO, and then the bubble study was negative. But it certainly looks like there's left and right heart involvement in this patient. Any questions, comments?
Did he by any chance have any metastatic carcinoid in the lungs themselves, or was it just the abdominal pelvic?
Yes, that's right. Yeah. So I think he's just started chemotherapy, and so we'll be having some follow-up echoes and MRs to see if this improves. Any other comments?
Carol, that's a great case. Thank you for sharing. Did he have any nuclear medicine studies to look for medicine anywhere else, and how do they look, the ones in the heart? Like
yeah, let me just pull him up here. He has not. All I see are CT abdo-pelvis.
okay.
And chest and echo and cardiac MR. Yeah, it's a bit strange that he hasn't had any other any nuclear medicine studies.
Cool. All right. Thanks.
Okay. I have another one here. This was unfortunately I couldn't download some of my angios because they're AVIs and I can't figure out how to get them to work on my Mac. So I'm missing a few images, but I think you'll get the gist. This was a 54-year-old man, very unfortunate, with a 1-month history of abdominal bloating, leg edema, and new syncope. And so he had a PE scan to start out with. Oh boy. Yeah. He had, I'll give you a little bit of history. He'd had 2 or 3 echoes at an outside institution. And did I present this case before, Jacobo? I don't think so, but
It doesn't
he
matter.
had
You can
2 or
present as
3
many
echoes.
times.
I'm having a deja vu. He'd had 2 or 3 echoes at an outside institution, and they thought he had a pericardial effusion. So eventually this PE scan was done. I think everyone can see this very large mass in the right atrium and ventricle starting at the SVC-RA junction, pretty much almost completely occluding the inflow to the right atrium, also almost occluding the inflow to the right ventricle. It's extending into the pericardium, and probably across the interatrial septum here. In addition, there's reflux of contrast into the IVC and hepatic veins. There's almost like a fluid level in the IVC, so probably a bit hypotensive. There's bilateral adrenal masses. Not sure if you can see my pointer. And so a few hours later, it's also maybe fading into the coronary sinus here. So a few hours later, as they were deliberating how to make a diagnosis of this, he had an abdominal CT, which didn't show anything more than the adrenal masses. So he eventually collapsed at a peripheral hospital, was transferred to the Heart Institute where I work, and had firstly an angiogram, a left heart cath and a right heart cath, and you can see the right coronary artery looks a bit narrowed, but it's not, doesn't appear to be very vascular, this tumor or a thrombus. Then had multiple, had a dilatation of the SVC right atrial junction and multiple biopsies. The right atrium was also balloon dilated, and then had a follow-up CT afterwards to look for any improvement. So what would be the differential for this large mass in the right atrium, right ventricle?
I'm happy to take as many cases as I can. I think I might be the only resident here, but I guess with the fact that you have those bilateral adrenal masses, I guess the most common things being common metastasis to the heart or a primary, I guess angiosarcoma would be the most likely if it were a primary cardiac.
Mm-hmm. When you see right-sided cardiac tumors, there's one more that you should probably mention.
I'm not not sure what it would be.
Okay,
Starts with
so
an
the
L.
last one,
I know the answer, but it's not fair because I know the case.
you know the case. Juliana's reminds. But you should know in general. So the three is firstly Mets and angiosarcoma, and always mention lymphoma, which often will affect the right heart. So you can see here, they didn't really improve the inflow a whole lot, and there are bilateral pulmonary emboli. I'm sure you can appreciate. There are probably tumor emboli at this point because they took multiple biopsies of this because it was the only, fast way to get a diagnosis. And at any rate, this patient remained on pressors and was eventually transferred to the general ICU to begin chemotherapy. But collapsed and at the time of transfer, and they decided to just palliate, and he passed away within a couple of days of presentation. And this turned out to be a diffuse large cell lymphoma. So one of those three bad things.
So I think Dr. Kirsch, you also showed a B-cell lymphoma at one of the recent case conferences, but I think the thing that I found interesting was that I guess it's so focal within the heart itself. You said that on the abdomen pelvis, it didn't seem like there were any other sites of metastasis, but I guess that's also the one that I left off of my differential.
Yeah, quite strange. In retrospect, I checked, and I don't think he had an autopsy. They did make the diagnosis from the biopsies. There are the adrenal masses, and I guess often with lymphoma, things retain their shape even though they get enlarged. I'm not saying that makes me think of lymphoma, but they're not rounded. They still have their adrenal shape. And then I keep wondering whether there's thickening of the wall of the stomach. To me, and I know the stomach is always a very, very difficult area to assess on CT, but it seemed like there was some focal thickening that persisted on a few of the CTs, but none of the abdominal imagers agreed with me. So seeing as I'm a cardiothoracic imager, I believe them. So yeah, a little bit strange, but from someone who just had a basically 1 month history and then just crashed and burned and passed away within a few days. It's pretty spectacular.
Yeah, Carol, this is Karen, and it's an amazing case. And it's interesting that last week I had a similar case here at University of Washington, and that's the first time I have seen a cardiac tumor presenting as an acute cardiac event. So this patient presented with acute chest pain, had a huge mass, just like you showed. I think this one was an angiosarcoma, and it ruptured the right atrium out of nowhere, and he had the partial. It was this contained thrombus, and patient, that was the first presentation of the cardiac tumor, and I thought it was the first time I've seen anything like that. And now you present another case of acute cardiac presentation of a tumor. There is all this discussion every time we have a ginormous cardiac tumor and patients need to undergo chemotherapy, that the tumor is going to involute and cause a cardiac perforation. And as I'm aware, and I've seen multiple discussions in conferences, that very, very rarely happens. But here we're seeing the tumor itself growing and causing either outlet obstruction or in my case, perforation. So very, very terrible but interesting cases.
Yeah, wow. If I can get the angio to work properly. It was pretty impressive. The IVC was injected, and you could just see the lobulated internal structure. It's and reflux into the azygos. It was pretty spectacular. Yeah. I have a companion case, I guess, a 76-year-old man with chest pain and shortness of breath, who presented in February, and one of my very astute colleagues read the chest x-ray. Am I going to pick on you again? What's yeah, go ahead.
I'm happy with that. So I guess there's a right-sided mass, which I would guess would be in the posterior mediastinum, kind of towards the base on the frontal radiograph.
So if it's in the posterior mediastinum, where should you look on the lateral then?
So we should see it abutting the spine, which we're not seeing.
Yeah. So it's probably not posterior, but it's, I mean, I really don't see anything on the lateral view. So I guess it could be abutting the heart, especially since I said it was a companion case. I gave myself away here. But so yeah, so he had this abnormal contour to the right heart border picked up, and had us started out with a CT, and I just have a still image of the CT, so kind of similar to what I just presented, although quite a bit smaller. And so here began his workup, which an MR followed. This is a cine image, axial image of the mass, which has a, it looks like a thick outer soft tissue component with a brighter inner core to it. No pericardial fluid. It's abutting and compressing the right atrium, but doesn't appear to be invading into the right atrium itself. Haven't had time to label these, but I think this is T1, and T1 fat set is on the bottom left. On the right upper is a T2 spare, and then this is on the right bottom is post-GAD. So there's some hyperintense components of the mass on the T1 fat set and T2 spare that kind of correspond to that low or high intensity center on the cine. There's enhancement of this on the late gadolinium images, but the central portion that was hyperintense is hypo or doesn't enhance with GAD, and so perhaps necrotic or proteinaceous material. A little bit out of sequence here. This is the perfusion, and it doesn't enhance super avidly, but maybe it's just we didn't scan long enough to see the enhancement. There's not enough heartbeats. Some haste images, I probably should have started with that, just to give you a lay of the land. It's difficult to see the right coronary in here. I think it's right here. And this is a post-GAD vibe image. There's no lung nodules. Here it looks like it's quite avidly enhancing. So this was February was the CT. By this time, this is March. It's kind of how things work in Canada. You guys probably would have done all of this in the same day. And he had a preoperative coronary angiogram because at first it was felt that it might be resectable. So they wanted to clear the coronaries because he's 76 years old. And so here you can see that there's tremendous supply from the right coronary to this mass. It's very, very vascular on the angiogram. And then it was actually my husband who was going to remove this, and he saw the supply coming from the LAD as well and was quite perturbed that perhaps this had grown because now it was May 6th and that it was probably no longer resectable. And so he went ahead and we did a CT at this point, which was May 10th. And now you can appreciate that there are nodules that are enhancing throughout the pericardium. Pretty much a nice display of all of the pericardial recesses by now. And the tumor is much, much larger. And you can see the right coronaries. With angiosarcoma, it often courses right in the middle of the tumor. So this was a bit unusual in that it was just displaced and still surrounded by fat. And there's some deposits here and there within the pericardium, and this was the area that was supplied by the LAD right at the left ventricular apex. So my husband had a very scary time biopsying this tumor. First, he tried to go subxiphoid and get a piece of it near the left ventricular apex, and it was just exploding with blood, and he was kind of putting stitches into pretty much anything, and eventually didn't make a diagnosis. The path came back as just blood. So he subsequently went back in and through a right thoracotomy and got a bigger chunk. And that was also very, very scary because it was also extremely vascular and bleeding, and he did get enough to make a diagnosis of angiosarcoma in this case. So we're just missing a case of METs. Did anyone bring right ventricular METs today? Any questions, comments?
You showed some carcinoid mets. We'll take that one.
Aha, okay. Yes, they were in the right heart too.
Yeah. Great
I
case.
think it's absolutely not fair that you have direct access to the cardiac surgeon and we don't.
Well, he has direct access to me too, which is often not much fun because he makes me look at stuff when I'm not working.
I have a silly question. I guess when you were closer to the apex and you were showing that first nodule that your husband went after. So in this area right here, why can't you just do a core-needle biopsy like right peristernal to get to that mass? Because it's not the right ventricular wall. I mean, that all looks like mass. Why is that not safe to do that?
I would imagine the patient would have probably tamponaded right away because it's extremely vascular and it's a closed space, and it would have just started bleeding. And so that was, I mean, certainly we considered it at first, but then we thought it might be too vascular. And just from his experience, after he told me, like, he had direct visualization and he couldn't stop the blood from coming out, and he was just trying to put stitches in jello, like it was I think the center is quite necrotic, and it was just, he was just sewing through. Yeah. So I'm glad we didn't try. Would anyone else have tried?
Absolutely not.
No.
Thank you.
That's all I have. I mean, I have some more, but I think it's close to 4 or 5.
We have about, yeah, we have like a couple more minutes. Is it anybody else has cases?
I have one case I could try to show, but you know, I have some problems with sharing my screen on this thing.
Should we do
And
that,
he's
Carol?
saying
Let's
here
see,
that
let's see
my
if
screen.
Karen can present one and you can save those other ones for next month. Let's see. Karen, I'm going to make you presenter and you have to accept and see if it works.
That's what we tried last time. Have to accept.
Did you get the invite?
No. I didn't
See,
get
you know what? No,
invite.
because I have you logged in twice. Let me see if the other one.
Aha.
There you go.
Okay, but that's not what I wanted to share.
We see your purple
Yay.
screen. There you go.
Do you see my case?
Yeah. Yeah. There's a heart in
You
it.
see a heart? You see, I'm kind of doubting that actually worked. Okay, so very quickly, this is a patient that presented, a 44-year-old male presented with peripheral eosinophilia and terrible acute heart failure. First thing they thought was COVID cardiomyopathy. He was COVID negative. And you can see this very, very abnormal left ventricle. It's enlarged. There's global hypokinesia, but especially the lateral wall is very dysfunctional. And then I have a short axis C to show too how it was very dysynchronous and enlarged, and the ejection fraction was like 20%. So severely ill with this pericardial effusion as well. So we did a cardiomyopathy protocol, and here is just a walker showing you that as the inversion time goes on, you see that rim of inversion in the subendocardial region, and then the normal myocardial nose. And even in the walker, you can see this global subendocardial late gadolinium enhancement. Let me show you some of the late gad acquisition now. So this was the 4-chamber. And you can see again how there was the subendocardial late gad all the way around. Septum, lateral wall, inferior wall, and anterior wall. So look at this impressive image here, subendocardial all the way around. Some in the papillary muscles as well. And this is our short axis. Let's see where's the short axis. You know, looks like the short axis LGE didn't come through, but I'll show you the T2 weighted images. It's some artifact, but there's basically this bright subendocardial signal that matches the areas of late gadolinium enhancement right here. So what would be your differential diagnosis? So first thing I heard, my travel thing is like, oh, there's a classic case of amyloid. That's what he said. Because there's this global subendocardial late gadolinium enhancement. But the key here is the acute presentation and the fact that the patient, that there's no hypertrophy. There's instead wall thinning of the entire wall. So this is a pattern that is usually described as amyloid pattern, but it's also the most common pattern in eosinophilic cardiomyopathy. And this is what this patient had, eosinophilic cardiomyopathy. And patient got steroids and improved significantly within 1 week of treatment. So So not
Cool.
COVID, not amyloid.
I guess it could be a subendocardial vasculitis as a differential. Like,
Usually it's not all the way around involving all segments, but that's a great, that's exactly what I said. I said Church-Strauss, but we are not supposed to say Church-Strauss anymore. So
yeah.
it was in the differential segments. Yeah.
Was there a little thrombus there along the septum?
Yeah, I looked at that for a long time, but the CT images don't confirm that that's a problem.
Yeah.
And
You
I
mentioned,
didn't put all the.
Karen, you mentioned at the very
Yeah.
beginning the patient had a hypereosinophilia.
Yeah, patient had peripheral hypertension.
Oh, I missed that. I missed that.
Yeah, and that was the only abnormality he had, plus the acute heart failure. So. And they did all rheumatologic tests, and nothing was abnormal.
So idiopathic.
Yeah. So now that I know how to share my teaching file, perhaps I can show more cases in the future.
Yes, that's it.
Except you have the diagnosis up there.
All right, that's great. I'm looking at the chat box. Dr. Hamid, do you have so you have a case you want to share? We can do 2 more minutes if everybody's okay with that.
Yeah. Let's see how it works.
All right, let me see if we can make us a presenter. Thank you, Karen.
Thank you.
All right, let's see if we can get one more case, squeeze in one more case before we go. All right, we can see your screen. Cannot hear you though. Cannot hear you and can no longer see your screen. Cannot hear you for some reason. Okay. Oh, okay. So you're not muted, but I don't hear. Anybody hears us? No.
No.
All right, we'll leave it for next time.
Yeah.
See if we can get your microphone checked. Thank you though for trying. Really appreciate it. So we'll try to get on it in the July session. So again, thank you everyone for making it. Thank you everyone for preparing cases, for asking questions, working in the chat, just being a part of it. Really appreciate it. Hope it was worth everybody's time. Have a great rest of your day, rest of June. See you in early July. Take care, everyone. Stay well.
Thank you. Thank you very much.
Bye. Thank you.
Maybe at the next session we'll have more residents participating because